Good afternoon, everyone. I'm Darcy Holladay Ford, the Director of Research here at CIVHC. Today, I'm going to discuss the effects of COVID-19 on healthcare costs at the end of life in Colorado during 2020 and 2021. Just a little bit of background on CIVHC. CIVHC is an independent nonprofit providing unbiased data and resources to improve health outcomes across Colorado. As the administrator of the Colorado All-Payer Claims Database, we have and maintain a database of over 1 billion medical, pharmacy, and dental claims from over 49 commercial insurers, Medicaid, Medicare, fee-for-service, and Advantage, covering more than 74% of Colorado's insured population. However, the Colorado APCD does not include claims from ERISA covered, about 50% of those self-insured plans, TRICARE, Indian Health Services, or uninsured individuals. A definition of end of life. End of life care refers to the support and medical care given surrounding death, often spanning days, weeks, or months before death as individuals manage chronic illnesses. CIVHC has focused on end of life care since 2019. Our goal is to guide discussions on serious illness and advanced care planning. Today, we're presenting a cost comparison between COVID, cause of death, and non-COVID during the years of 2020 and 2021 for the end-of-life care. Just a bit on the background. Previous studies have found disparities in end-of-life care. For instance, care intensity and access to hospice services varies by insurance type, according to Yang and et al. 2020. The pandemic has exacerbated these racial disparities in care, making findings especially relevant today. Coming from 2021, as well as the pandemic's place of death among Medicaid and commercially insured individuals with cancer is also observed during COVID-19. So our study examines healthcare costs for Coloradans who passed during the COVID-19 pandemic, again, through either cause of death of COVID or not a cause of death of COVID during 2020 and 2021. We looked at three things. How do demographics impact costs? How did costs for COVID-19 related deaths differ by payer type? And how did dual eligibility for Medicare and Medicaid affect these costs? We conducted a respective analysis of medical and pharmacy claims from the Colorado APCD for individuals who died in 2020 and 2021. We excluded traumatic deaths and anyone that had fewer than 6 months of insurance eligibility. Our final study cohort was 51,559 distinct Colorado APCD members who died in 2020 and 2021. We calculated cost on a per member per month basis to standardize comparisons. We then stratified the data by key demographics such as age, race, insurance type, and dual eligibility to identify patterns in care. A large portion of our population, about 59%, was over 75 years old. 65% were non-Hispanic whites, which aligns with Colorado's demographics, but only represents the insured population. In our study cohort, 11.9% of individuals died from COVID-19 in 2020 and 2021. Percentage of deaths due to COVID rose slightly from 11.5% in 2020 to 12.3% in 2021, with a total of 6,110 deaths overall during these periods. Looking at COVID-19 deaths by race and ethnicity, disparities became evident. Non-Hispanic whites make up the largest proportion of deaths. However, minority groups, particularly Black and Hispanic populations, experienced higher relative mortality rates, reflecting broader inequities in healthcare access and outcomes during the pandemic. COVID-19 disproportionately affected older populations in our study in 2020 especially. Most deaths occurred for those over 75, reflecting the vulnerability of this age group. However, we also saw an increase in percentages of deaths among younger age groups between 2020 and 2021, likely due to factors such as delayed vaccine access and shifting patterns in the spread of virus, as well as employment. Healthcare costs calculated per member per month basis in 2020 were generally higher for members dying of COVID when compared to other causes of death. This can be seen across all payer types, with commercial plans seeing the highest costs. In 2021, these costs increased further across all payers, reflecting the ongoing financial burden of the pandemic. Commercial insurance remained the most expensive, while Medicaid and Medicare also saw significant rises in per member per month costs. When we break down COVID-19 related deaths by payer type, we see distinct patterns. Commercial plans have fewer deaths overall, but contribute to the highest per member per month cost. In contrast, Medicaid and Medicare saw more deaths, but the cost per member were generally lower. These differences highlight the varying financial impacts of the different payer systems during the pandemic. Dual eligible individuals who were enrolled in both Medicare and Medicaid saw a sharp drop in the COVID-19 deaths, from 46.6% in 2020 to 25.1% in 2021. While the vaccine rollout played a major role in the decline, increasing Medicaid enrollment during the pandemic may also have contributed by providing broader access to healthcare and resources for vulnerable populations. Commercial plans typically had shorter coverage periods, averaging between 2 and 4 months, while Medicaid and Medicare had longer coverage, averaging 9 to 11 months, indicating that individuals with public insurance had more consistent healthcare access, leading to their deaths. Commercial plans were only used as a high-cost supplemental treatment, and even with 2 to 4 months averaging, the costs were exponentially higher. There's several important limitations to our study. First, COVID-19 deaths have been classified differently across jurisdictions, leading to inconsistencies in the data. We use death records to identify cause of death, and the primary cause of death of COVID-19 was not always indicated. Second, the APCD only includes the insured populations, which limits our ability across generalizability across the uninsured as well as other states. And we also know that race and ethnicity data are reported by the payers and are not always reflective of individual self-identity and are oftentimes not reported. COVID-19 increased end-of-life costs across all payers, with commercial plans hit the hardest. Disparities in care remain, especially for vulnerable groups. More resources are needed for end-of-life care and future pandemics to reduce inequities and financial strain across all age groups, ethnic and racial categories. Here are a few of our references, so you can keep those handy, as well as our contact information. Thank you so much for your attention. We'd like to open the floor to any questions and you have any feedback. Thanks so much. If you have any questions or follow-up, please outreach us. You can reach this abstract here, as well as my contact information and information about CIVHC.